This final session is on VATS Lobectomy, on VATS segmentectomy, on VATS trauma. I'm chairing the session and I now have to introduce myself as the first speaker as well, which is slightly bizarre. I'll leave it to you to think how I should introduce myself. A song? Okay, that's right. Yeah. I could mime something. Yeah, okay. So the next two speakers, we've got Renee and Ian, have got very specific titles, and I've got this rather woolly title of VATS Lobectomy, Impact on UK Resources. I was given it with no particular instruction, and people I've spoken to so far, I've got no idea what I should talk about. So bear with me, and we'll see how things go. So this is what we're here for, isn't it? This is VATS Lobectomy. This is something that we've been doing thanks to Renee in Copenhagen for the last 4 or 5 years with some very good results, and we are ardent supporters of VATS Lobectomy. But why do we do it? Why, as a group of surgeons, have we been so enthusiastic about doing VATS Lobectomy? Is it because it's cosmetic? Well, we're seeing there's little scars there. Is it because it's less painful? A quicker recovery? There's a shorter length of stay, people say. Better quality of life as well. The patients like it. They get back to normal more quickly. They're more likely to complete adjuvant chemotherapy, and there's some suggestion that they might have a better long-term survival. Or is this actually all true, or is it myth? Are we believing something which isn't actually true? There are so many publications now about VATS Lobectomy, so many, and each year a new one, each month a new one comes up to say how wonderful VATS Lobectomy is compared to thoracotomy. The reality is that there's only 4 randomized controlled trials published so far, and they're all underpowered and didn't show a great deal. Here's of some of the better quality papers. Here's one from 2013. This was the biggest meta-analysis so far. 20 publications, over 2,000 VATS lobes, which showed an improved 5-year survival for VATS. It's amazing, wasn't it? A survival benefit of 5%. So we should be doing VATS lobectomy to make our patients live longer. Or even more recently, the beginning of this year, VATS lobectomy has better perioperative outcomes. So this is for stage 1 and 2 non-small cell lung cancer. And it was quite a big propensity matching exercise with 175 pairs, and it showed that the VATS group had reduced length of stay and reduced complications, although there was no survival difference. But still, it seems that VATS lobectomy is better. And yet, this is not a randomized controlled trial. This is a propensity matched analysis. And if we're prepared to believe this propensity matched analysis, are we prepared to believe the propensity matched analyses which suggest that SABRE is as good or maybe even better than lobectomy or lung resection for lung cancer? So we've just got to be a little bit careful here when we're interpreting the literature. And then this is the most recent thing, which isn't published. It's published online. It's not been published. This is a huge analysis by the European Society, and Renee, you're one of the co-authors on this. And looked at, they mined the database, the ESTS database, of which there are around 30,000 patients, of which 2,700 had a VATS. So only about 10% of patients had a VATS lobectomy. And but they matched them to 2,700 matched pairs, and in the VATS group, they showed a lower incidence of complications, so 29 versus 31%, a shorter length of stay, still long though, at 7.8 versus 9.8, and a lower mortality of 1 versus 1.9. At the moment, this is the best evidence, I think, that we've got that VATS lobectomy is of benefit when compared to thoracotomy, but it's still not a randomized controlled trial. It's a propensity-matched analysis. And we've been lapping this up. We've been lapping up these sorts of papers for the last few years now. And because of this, the American College of Chest Physicians, in their guidance on the treatment of lung cancer, has said that in stage 1 non-small cell lung cancer, all patients should be offered a VATS lobectomy if appropriate. And that differs from NICE guidance on lung cancer, which just says it's all right to do a VATS lobectomy. It's not an active recommendation to do a VATS lobectomy in stage 1 lung cancer. So let's just go back a little bit and look what has happened in this country with a different sort of cancer. So LAPCO is an admirable initiative to do with colorectal cancer surgery. LAPCO is the National Training Programme for Laparoscopic Colorectal Surgery, and it came about in 2006 after a NICE technology appraisal. The NICE technology appraisal itself came about because there were 3 large randomized controlled trials comparing open versus keyhole surgery for colorectal cancer. And interestingly, none of those trials showed that laparoscopic surgery was particularly better than open surgery, either in terms of quality of life or pain. But it did show a reduction in length of stay, and it did show that they were equivalent operations. So in other words, they were non-inferiority trials. But because of that, NICE said that laparoscopic surgery should be offered to all patients in the UK with colorectal cancer surgery. And at that point in time, only around 5% of patients were having a laparoscopic colectomy, and now it's around 45%. And so this is an active decision by central government to have a new technology incorporated into cancer care. Fine, so let's go back to lung cancer then, and this is an old slide which you all know. Primary cancer, the use of VATS lobectomy or VATS in lobectomy procedures. And for many years, just Bill Walker was plodding along doing his VATS lobectomies. And then over the noughties, then a few more people took it up. And then in 2010, there was this big jump as more and more people got into it. But this data is a bit old. And so this is the newest data that we have. This is courtesy of Doug West. So we're doing around 4,500 lobectomies for lung cancer a year at the moment. And we've gone in the last 3 years from around 16 or 17% up to it's actually 30% now. So in 2013-14, which is the latest data we have, 30% of all lobectomies for lung cancer in the UK are done VATS, which is fantastic. And at the same time, mortality has fallen. Look at this. So for open surgery, we've got a mortality which stays much the same at around 2%. But for VATS lobectomy surgery, our mortality is now down to 0.6%, which is really quite remarkable as well, although there's clearly a load of selection bias going on there. So you've seen this slide a couple of times today already, and I can just go into it in a little bit more detail. So this is actually the proportion of lobectomies performed VATS for lung cancer as broken down by unit, and it's pretty complete apart from Sheffield. Is anyone from Sheffield here? So Sheffield has not submitted their data, but but Doug tells me it won't affect the results particularly. So we have some centres who are not doing very much at the bottom, and then we've got Bristol, obviously, at the top here. But the average is 29 to 30%. And you have to ask, as Mick Peake asked earlier on as well, what's going on below the 30% mark, and why are we up at 60 to 80% in the top performing centres? So, what stops you from starting a VATS lobectomy programme? And there are a number of things, and we've touched on this. Tom's talked about this in terms of VATS training. But there's still this perception that it's a difficult operation. And it is quite a difficult operation, but anyone trained as a thoracic surgeon should be able to do a VATS lobectomy, because if you adopt a standardised approach, it's actually very reproducible and quite easy to teach and to learn. There's still this argument that it's unproven, it's an unproven cancer operation, and there's inadequate lymph node dissection. We know we can get adequate lymph node dissection. Tommy D'Amico has shown that. But the naysayers are a little right in that it's unproven at the moment because we don't have that RCT evidence. There's this big fear of bleeding. Tom, you've talked about that already. Bleeding is really rare in VATS lobectomy. If you look at conversion rates in the world literature, then it's around 2 to 6% conversion, of which around a third of that is for bleeding. So in a centre like René's, where you have a 2% conversion rate, your conversion rate for bleeding will be less than 1%. Or thereabouts. That's what it is. It's a rare complication, so you shouldn't really be scared of bleeding. But to do with this talk, what about resources? And people worry about training, because it takes resources to train, and you have to take time out and time away from your family. Time, you've talked about this already, time in the operating theatre, time to learn the new procedure. The startup costs as well, which we can talk about in a moment, and the operating room costs as well, and why this might be difficult for your management team to buy into. And then in a hospital with a VATS lobectomy program, why don't you do more VATS lobectomies than you're doing at the moment? Because most hospitals are clearly doing VATS lobectomies. That's what we can see from that slide, but a lot of them are doing less than 30%. Is it because of the tumour itself? And I think that's a lot of it, people only wanting to do tiny little tumours or the tumour location. Or again, is it down to resources? Is it the time? I know, Rajesh, we had this conversation about Manchester, maybe not having the time during your operating day to do 2 VATS lobectomies and something else. Is it the instrumentation that your trust isn't prepared to buy the instruments that you need? Or is it that not all surgeons are trained? And arguably, if there's just one person in a hospital doing VATS lobectomy, then it's going to be very difficult to get that VATS lobectomy rate higher. So just to go back here, T&M, so this is the Violet study, which we can talk a little bit about if you want. So this is due to start recruiting in the next couple of months, and the inclusion criteria for patients in the Violet study are exactly the same as the International VATS Lobectomy Consensus Statement, in that the tumour has to be T1A to T2B, in other words, less than 7 centimetres, N0 to N1, and beyond the lobular orifice. This is most of the patients you do lobectomies on in normal life anyway, open. So the T&M of the tumour itself shouldn't really stop you from doing a VATS lobectomy. So what about resources then? Let's look at my unit, Bristol, as an example of what is now a resource-rich unit, and that's come about because of the VATS lobectomies, the program that we've introduced. Why do we have an 80% VATS lobectomy rate? Well, one is because all surgeons perform a VATS lobectomy, so I think there's just Bristol and Leeds in the UK where all surgeons perform VATS lobectomy. But we have a dedicated thoracic theatre. No? Oh, you've got, go on, tell me. Southampton as well? 4 in Sheffield? Oxford? Oh, sorry. Oh, Norwich? There we go. 6. Fantastic. So you will already be centres way up in that first quartile with high VATS lobectomy rates. You should have a dedicated thoracic theatre. We have a thoracic theatre we've got a beautiful new wireless stack system. It's not quite as beautiful as your operating theatre, René, but it's still pretty good. 6 VATS lobectomy trays, so that was a major investment so that we can do up to 4 VATS lobectomies a day. We have time, we do have the luxury of time, although we're much quicker now, so we're not pressed by our management team. If we put 2 VATS lobectomies and something else on the list, then they're happy with that. But we have a very robust mentoring process as well, and we help each other out, which I think is crucial to getting the VATS lobectomy rate up. This is Rakesh yesterday operating, and we actually have a very simple setup. René, you'll recognise it as looking very similar to Copenhagen, or as Mel said when she went to Copenhagen, that Copenhagen does a Bristol VATS lobectomy, which is a great compliment. But the tray itself is not expensive. So in terms of the startup costs that we were talking about and resources, you all have a high definition VATS stack, and we have the luxury of 2 because that's how Copenhagen do it, and that's how we thought we should do it. So you all have access to that. So that shouldn't be there in your startup costs. The instruments are very cheap. The most expensive instrument here, actually, we've just bought some D'Amico mediastinal lymph node graspers, which are fantastic, and Diego uses them all the time, so they cost £2,000. But the next most expensive instrument is a curved Rampli there, which costs £80. So the instruments themselves are actually very, very cheap. So one of the other arguments is that it's too expensive. So the startup costs are there, yes, they are there, but the trays are relatively cheap, and you've all got the HD stacks. So the other argument from management is that it's just too expensive and we shouldn't be doing this, and Frank talked about this a little bit earlier on. So the seminal paper by Casali and Walker back in 2009 said, VATS surgery, can we afford it? And they looked at overall hospital costs And although they show that the operating room costs were slightly higher, the overall costs were lower. And this was as a result of the shorter length of stay and reduced HDU use. So this is slightly disingenuous to say that shorter length of stay results in a cheaper operation, because that's not quite true. What it results in is increased access to bed base, increased patient flow, and then over time you might be able to lose some beds and save some money that way. But as an immediate cost relief of cost pressure, it's not completely true. This is an interesting paper that's come out 2014 from the States. I think it's from Seattle, and this group looked at 90-day costs of VATS compared to open surgery. And they mined one of their insurance databases and found that of around 10,000 patients, 31% had a VATS operation. They showed that VATS was associated with a lower likelihood of prolonged length of stay, fewer readmissions, and fewer emergency department attendances over that 90-day period. So in other words, these patients seem to have less contact with healthcare in the first 3 months after their operation. And because of that, their costs were over $3,000 lower for VATS lobectomy in a three-month period than they were with open surgery, although almost all the cost saves were due to fewer episodes of prolonged length of stay. So this is all great, and everything we've talked about so far is great, and it's what we've bought into and why we do VATS lobectomy, but we still don't have any real evidence. There's a really nice article in the BMJ a couple of weeks ago about the state of evidence and systematic reviews, and how systematic reviews are based on the literature that's available, and the literature available is largely of poor quality and flawed, because it's made up, even if it is a randomized controlled trial, of underpowered or poorly designed randomized controlled trials. But I think we still need a trial to see where we're going in VATS lobectomy. So I've the privilege of just showing you some data now from Peter Licht's group in Odense. So you've seen this data already, René. So Peter, who some of you know already, has just completed the largest randomized control so far of VATS lobectomy, of VATS versus anterior lateral thoracotomy. 206 patients randomized. It's not published yet, this. What they've found is very interesting, that pain experienced in less patients at 12 weeks, and that's it to do with pain. So in-hospital pain was the same, pain at a month was the same, pain at a year was the same. The only difference they found was at 12 weeks, which sort of goes against what we intuitively think about VATS lobectomy being a less painful operation. They've shown little difference in quality of life as well, which is interesting, isn't it? Because when you see a VATS low patient in clinic, I guess we're just remembering the good ones, the ones that do really well, come bouncing into clinic and have gone back to work within 2 weeks of their surgery. But apart from some of the more subtle things in the quality of life score, they showed little difference across the whole time period of a year. What they did show was a shorter length of stay, 4.8 versus 6.7 days, so both are short. And what's important in terms of resource is that it's more cost effective to do a VATS lobe than it is to do an open lobe. You save around £700 just from the hospital stay, but over the 52 weeks of follow-up, over the following year, you save over £2,000, and that's primarily a result of a reduction in readmissions to hospital. So, how does this translate into UK practice? So I've done some back of the envelope calculations here. So let's just assume that we do around 4,500 lobectomy operations each year for lung cancer, which is about right. Let's assume that the costs in the NHS are the same as in the Danish health system. Let's assume that we're incorporating some elements of enhanced recovery or fast-track surgery, because that was clearly the case in the Odense paper, to get those lengths of stays down to that. So how does that translate then? So currently, if we've got a 30% VATS lobectomy rate, for the UK as a whole, we might expect to save around £945,000 and nearly £3 million for the whole year. Let's say we got up to where we are at the moment at 80%, which I don't think is realistic. and we can maybe save £2.5 million in hospital stay and over £7 million for the first year. What is a realistic expectation, though? I mean, Tom, you've picked 50%. Is 50% a realistic expectation? I have no idea. I don't think any of us really know what the realistic expectation of how many VATS lobectomies we should be performing, but even at 50%, there are substantial cost savings which could be achieved by adopting VATS lobectomy throughout the UK. So what next? Will Violet produce similar results to the Adenso study? Violet, as one of the secondary outcome measures, is going to look at the health economics and the cost effectiveness of VATS and open surgery over a 1-year period. Will that result in updated NICE guidance to mirror what we see with the ACCP guidance? And will that in itself bring about a thoracic LAPCO, or is what you guys have talked about already, is that what you're trying to achieve with your STS education program? So just to conclude then, VATS lobectomy is not inferior to thoracotomy. I'm not sure we can say it's better than thoracotomy, but we can definitely say it's not inferior to thoracotomy. VATS lobectomy is associated with a reduction in length of stay and appears to be more cost-effective than thoracotomy. A low VATS lobectomy rate is likely due to a number of factors which we've addressed already today, including access to adequate resources. But a higher VATS lobectomy rate may deliver considerable efficiencies for the NHS. Okay, thank you very much.
Just a comment for the economical calculation in the Odense study. In the open cases, they use stapler the same way as they use the VATS. That's a very important point, I think, because a lot of countries use suturing for the vessels. And thereby, there's a difference in the number of staplers used in the theatre. That's an important point.
Yeah, thanks, René.